Right, okay, I'm just going to be talking about scoring systems used on the ITU. And firstly, I'm going to talk about the ideal scoring system. I always think about an athlete and they're trying to score, and one of the most important things with sport is that you pace yourselves. So I've come up with a mnemonic, paced. P stands for predictive. It needs to be able to predict whatever it is that it's intended to predict. That is mortality, functional status, severity of disease. It needs to be applicable to a wide group. That is to say, there's no point in saying it only works for 27-year-olds, but a 26-year-old, no, that won't work. C, it needs to be calibrated. Is a higher score more risky than a lower score? E should be easy to perform. There's no point in using a test. Well, that's not true. Ideally, a test is simple to perform, particularly in the day-to-day practice, but if it's for study or research purposes, then it can be complicated, but don't expect it to be used in day-to-day practice. It should be discriminatory, so it can work at a good level of detail between saying that one person is a higher risk than another, so you can use it for resource decisions. So that's just to go through it again. It should be predictive, applicable, calibrated, easy and discriminatory. With all scoring systems, there's that frequent caveat, which is that it shouldn't be applied to individual patients, but is more of benefit in comparing large groups with each other, to say this large group has a higher mortality than this large group because this scoring system tells us. And we all know that there's lots of factors that increase patient heterogeneity that we don't know about, or we don't include when making scoring systems. So let's just talk about what is predictive of poor outcome or increased severity. And I think, well, now, has this athlete of ours trying to score a high score taken a popper? So by that, we're talking about the physiological parameters. So have they got a low blood pressure, high heart rate, or high respiratory rate? We all know that respiratory rate, or we should know, the respiratory rate is one of the most predictive of high disease severity. What organ support are they requiring? Are they already requiring renal replacement therapy, for example, or are they on inotropes? Because the presence of renal replacement therapy or new onset renal replacement therapy in ITU is predictive of poor outcome. What was the primary pathology that brought them in the first place? What are the specific characteristics of the unit? What is the unit mortality that does affect outcome? And what physiological reserve do they have? And I think that's used as a surrogate really for age and other comorbidities. So that is, has your athlete who has paced themselves nicely taken a popper? So just to go through again, physiological parameters, organ support, primary pathology, that's your double P, unit specific characteristics and reserve. So just want to talk about scoring systems that are used in the ITU, GCS, Classic, Apache score. Remember, Apache 1 and 4 are proprietary, Apache 2 is the most commonly used. Simplified acute physiology score, the SAPS score, the MODS score, multiple organ dysfunction score, and the SOFA, a sequential organ failure score. Now you could try and remember this by taking a SOFA and putting Rabsy Nesbitt on it from Glasgow, an Apache Indian on it, somebody who's quite weak and pathetic, a SAP, and perhaps a Brighton mod on his scooter parked next to the sofa. So that's just to try and remember some scoring systems for talking in the exam. A SOFA, sequential organ failure assessment, can be performed on a daily basis. And on the SOFA, we've got sitting Rabsy Nesbitt as a GCS. We've got an Apache Indian. We've got some weakling who's a SAP. And we've got a mod with his scooter or Vespa parked next to the sofa, just to try and remember. Let's talk in more detail about the Apache score. So I'm going to try and explain how I'm going to remember the Apache score. I've got 4 Apache Indians standing outside an anaesthetic room. They're guarding the anaesthetic room. And that's to indicate that there are 4 Apache scores, or 4 iterations of the Apache score. And I go into the anaesthetic room, and on my left is a wide open cylinder of oxygen. It's spraying oxygen everywhere and it's hissing loudly. And what it is doing is it's blowing oxygen onto a fire that's next to it. So that's to represent oxygen, PO2 and temperature. And that's really stoking the flames, so the flames are burning brightly. And the flames are burning so brightly that they're catching fire to sodium and potassium, which are in big piles next to them, and they're phosphorescing everywhere. Just think about chemistry lessons at school where they burnt and burnt and burnt. And to make the situation even more dangerous, these Apache Indians outside aren't doing a very good job of guarding the room. I've got a vat of acid as well next to the sodium and potassium, and that's bubbling over, and it's burning a little critter next to the fire, and he's screaming in pain. So there we've got oxygen, the hissing cylinder, fire or temperature, which is indicated by the fire, sodium, potassium and acid, these terribly caustic substances lying around next to a fire, very dangerous, and burning a critter, representing the hematocrit. And then as I go around past the double doors of the anaesthetic room on the other side, we've got a white cell count. Now I always think of white cell counts, I don't know why, as somebody with a big pointy white hat, kind of like the KKK. It's not a very nice image, but it does help me remember it. And fighting with this person from the KKK is Rabsi Nesbitt, and he's been taking some creatine because he's trying to get butch. So that gives me a remembrance of the GCS and the white cell count. And that's a weird way of remembering it, but it helps me. Let's talk about some other scoring systems, just in case you're asked to give us some examples. Curb 65 score for pneumonia, Glasgow score for pancreatitis, the Ranson score for pancreatitis, the HIT score for heparin-induced thrombocytopenia, the Rockall score used for GI bleed, the Wells score for estimating the likelihood of a DVT, the CHADS2-VASc score predicting the risk of stroke in AF, and the Hasbled score predicting the risk of a GI bleed whilst taking anticoagulants. So here concludes the end of this particular